Good morning to our respected professor and my dear friends. Today our topic of presentation is blood glucose regulation. Why this is so important to regulate the blood glucose? See, all of our body organs need glucose as its metabolic fuel. Mainly our vital organs like brain and other vital organs need this glucose as its metabolic fuel for its metabolic pathways. So this glucose has to be maintained at a normal level, always not hyper, not hypo, because in case of if this disruption can lead to serious metabolic disorder. So this process is a very finely tuned process in our body occurring every day, and it includes huge number of hormones and multiple metabolic pathways. So next, what is the source of glucose in our body? So let's take an overview from this slide and we will describe it in the next slide. So dietary intake, which the food we take every day is a dietary intake, which we take carbohydrate as glucose source. And next is glycogenolysis, the breakdown of glycogen which is stored in our body like liver and skeletal muscle. Mainly here is the liver, because the glycogen stored in the skeletal muscle cannot be converted directly to glucose. So in case of any need of glucose, the glucose stored in the glycogen stored in the liver is directly converted to glucose and released into the blood. Next is gluconeogenesis, formation of glucose from non-carbohydrate sources and like lactate, amino acid and glycerol. So in the name you can see the gluconeogenesis. Neo means something new or something different. So next we'll describe this slide. In the demand of glucose and the source of glucose is depend on the different aspects. Like in the oil phase stage, the definition of oil phase stage is the time within taking food 1 to 4 hours of food intake. So in this phase, the main source of glucose is dietary glucose, and next is early fasting stage. The time 4 to 6 hours after taking food. In this case, the source of glucose is hepatic glycogenolysis, which is conversion of glycogen stored in the liver. Next is fasting stage. The time is 16 to 48 hours after taking any food. It's mostly 2 days. In this case, the process is gluconeogenesis, the formation of glucose from other than carbohydrate sources. Next is prolonged fasting, which is also called starvation. In starvation, the time period is if we don't take food more than 2 to 5 days, then the fat stored in our body, it's converted to fatty acid and start fat oxidation and form ketone body, which is then used instead of glucose. So in this case, there is no direct source of glucose present. So ketone body is used as energy. Next is prolonged starvation. If we don't take food for more than 5 days, there is prolonged starvation, and in this case, the structural muscle protein in our muscle is converted to energy and muscle proteolysis is occurred. So next is method of estimation of blood glucose. There are multiple methods present in nowadays. So the very first we are seeing fasting blood glucose. So fasting blood glucose is the estimation of blood glucose when we take the sample of blood from a patient who is fasting overnight more than 8 hours. This is mainly used in case of pre-diabetic patient and diabetic patients. Next is postprandial blood glucose. this postprandial blood glucose is when we take a blood sample from a patient who is after taking food of 2 hours. Okay, this is postprandial blood sugar, and in this case we see how our body is reacting to glucose and how our body is managing glucose. Next is random blood sugar. In this case, we take blood sample from the patient at any time, regardless of the when he or she ate last. So there are another method called oral glucose tolerance test. So in this case, we give a sugar sample to the patient. In the sugar, in the time difference, we take the blood sample and check the glucose level to see how his body or her body is reacting to this increase of blood glucose. So there are some enzymatic method also. One of this is GOD-POD method, glucose oxidase and peroxidase method.
You better come to the topic. You are away from the topic.
Yes, sir.
You have wasted almost 6 minutes on what which is not in the topic.
So further,
Blood glucose regulation is a topic, right? Is it a part of blood glucose regulation? You have only 10 minutes to speak.
so I will hand over the mic to Anusha.
So, in this slide, we can see the importance of regulation of blood glucose. As we know, blood glucose regulation helps to prevent hyperglycemia and hypoglycemia. It ensures continuous supply of energy to the brain. It also provides continuous supply to the muscles and maintains a metabolic balance. As we can see in the picture, when there is high blood sugar level, the pancreas releases insulin, which stimulates glucagon formation, which in turn stimulates glucagon uptake from the blood, which in turn reduces the blood sugar level. On the counterpart, we can see when the low blood sugar occurs, the pancreas releases glucagon, which stimulates glycogen breakdown, which in turn increases the blood sugar level. In this, we can see the stages of maintenance of blood glucose level. In the absorptive state or the phase state, we see the insulin domination. In the post-absorptive state or the fasting state, we see glucagon rises. In the starvation, which is shift to fat from derived ketone bodies. In the prolonged starvation, the brain adapts to use ketones for its energy supply. Now the organs involved in the maintenance of blood glucose. These organs are mainly liver, pancreas, muscle, adipose tissue and brain. Liver, glucose storage and production. Pancreas, it releases insulin and glucagon. Muscles helps in the glucose uptake. Adipose tissue for fat metabolism and brain for constant glucose demand.
So insulin in well-fed state, the beta cell of the pancreas secrete insulin, which normalizes the blood glucose level by increasing glucose uptake and glucose utilization. So, in well-fed stage, the beta cell of the pancreas releases insulin, which normalizes the blood glucose level by increasing glucose uptake and glucose utilization. So, it promotes pathways such as glycogenolysis, lipogenesis. So, when there is excess of glucose, it is converted into pyruvate, and the pyruvate is converted into acetyl-CoA by the help of the enzyme pyruvate dehydrogenase. This acetyl-CoA is then converted into fatty acid, which along with glycerol forms triacyl glycerol, which is stored in adipose tissues. Insulin also inhibits glucose generating pathways such as gluconeogenesis and glycogenolysis. So if we see the role of insulin in different organs, like in liver, it increases glucose uptake, glycogen synthesis, fatty acid synthesis, and decreases glucose synthesis. In adipose tissues, it increases glucose uptake, glycerol production, and triglyceride synthesis, whereas it decreases triglyceride breakdown. In muscle, it increases glucose uptake and glycogen synthesis. Glucagon. So in fasting state, the blood glucose level drops. That's why the alpha cells of the pancreas secretes glucagon, which promotes glycogenolysis, gluconeogenesis, and lipolysis. During prolonged fasting, the stored triacylglycerol is broken down into fatty acid and glycerol. This fatty acid is then converted into acetyl-CoA by the help of beta oxidation process, and from this acetyl-CoA ketone bodies are synthesized which act as a metabolic fuel. Now, the role of glucagon in different organs, we can see that in adipose tissues it increases triglyceride breakdown and decreases triglyceride storage. In liver it increases glycogen breakdown and increases
I think you better stop. You have crossed the time limit. Sorry. Now, it is not a place where you go on informing all about hormones. Stick to your topic. I told you. Stick to your topic. In a topic, glucagon, function of glucagon is not required. How glucagon is helping in maintenance of blood glucose, that is required. So your presentation, how you prepare the PowerPoint, that doesn't matter. It's okay, fine. But what you have prepared and what you have planned for preparation for the presentation, it was not correct. You violated all the limits. It's not like an essay. You should sink the topic. Okay, we have crossed the time. 15 minutes over. We stop this. Next group. Quick. 15 minutes হয়ে গেছে।
Two important points here were not covered. One is RBC is 100% dependent on ambient blood glucose level. That ought to be mentioned. Number two, among the organs, whatever they have told, one organ is conspicuously missing, that is gastrointestinal tract, the largest endocrine gland of our body. And without an intact gastrointestinal tract, blood glucose regulation will be practically impossible. And if you know that GLP-1 and GIP are both secreted with relation to blood glucose, they are most important hormones. GLP-1 it stimulates insulin secretion, it inhibits glucagon secretion, so that it basically lowers the blood glucose level. Gastric inhibitory peptide decreases the gastric emptying time. Ghrelin and mutilin, these are also gastrointestinal hormones. They are required. They increase the gastric emptying time. So if any mechanism is there which will bypass the upper GI tract, and if the food is directly delivered into the intestine, bypassing duodenum and jejunum, the blood glucose level will not be maintained properly, and there will be abnormal response. Second most important thing, our body system, intestine, is habituated with our own food intake. Any abnormal type of food intake at any given point of time will give an abnormal blood glucose regulation in any individual. So in your clinical practice, whenever you will be practicing, you must ensure that the patient is assessed under the normal food which he or she normally takes at his or her home. That will be the most ideal procedure for assessing the blood glucose regulation, and not by any artificial or abnormal food. Okay, that you must remember from a clinical standpoint. Glucose normally is used for glucose tolerance test, but nobody in the world takes 75 grams of glucose in the morning, and that assessment part will be almost totally wrong. And when you can do that thing for your examination purposes, but just remember that when you treat a patient, then before you start the treatment, you assess the patient with a normal diet, maybe a breakfast, maybe a lunch, and that should be exactly time when the patient takes that particular type of food. Otherwise, wrong results will be there and wrong assessment will be made while the patient will be in the treatment phase. Okay.
Good morning everyone. Today myself Asif Akhtar Khatun and my team members
Myself Bunty Mandal.
Myself Azmatullah Shadman Haq.
are going to represent on a topic conjugative hyperbilirubinemia. So here at first what is conjugated hyperbilirubinemia? Conjugated hyperbilirubinemia refers to an increase in conjugated form of bilirubin in the blood. It usually results in impaired excretions of bilirubin from the liver into the bile duct or obstruction of bile flow. Up next, we have bilirubin metabolism. Bilirubin metabolism refers to a process by which body breaks down hemoglobin from the red blood cells and eventually excretes via bile and stool. It mainly occurs in the reticuloendothelium systems and liver and small intestine. So,
চেঞ্জারটাকে এই পাশে নিয়ে আয়, হয়তো সিগন্যাল পায় না।
So, our blood contains RBCs. RBCs contains globular proteins which are called hemoglobin. Hemoglobin breakdowns into heme and globulin part. Then the heme part is converted into biliverdin. Then the biliverdin converts into bilirubins. Now the bilirubins is insoluble in blood and has to be conjugated. So it is then transported to the liver and mixed with the bile and forms a conjugated part of bilirubin, which is now soluble in blood. So it is then transported to the small intestine and then for the digestion of food, along with the digestion of foods, and then excretes via stool. Next. So here you can see the bilirubin is then transported to the liver, and then up next it is mixed with the bile and forms a conjugated part. Then it is transported to the small intestine. Then in the small intestine, along with the digested food, it is excreted out as feces, which is 80%. Next.
So now moving to the next topic is what is the difference between conjugated and unconjugated hyperbilirubinemia. In unconjugated hyperbilirubinemia, it is insoluble in blood, largely attached to albumin in blood, accumulates in prehepatic jaundice, is toxic to tissue and organ such as the brain, and it cannot be excreted in the urine. And now what is conjugated hyperbilirubinemia? It is water soluble, small amounts are loosely bound to albumin in blood, and it accumulates in posthepatic jaundice, relatively non-toxic, and it can be excreted in the urine. So up next, what happens during impaired excretion or obstruction? When there is blockage or impaired bile flow, the conjugated bilirubin can't be excreted into the intestine. Instead, back pressure builds up the bile ducts and hepatocytes. Conjugated bilirubin leaks back into the bloodstream. Since it is water soluble, it enters the urine, causing dark urine. Less bilirubin reaches the duct, so stools become pale. Causes of impaired obstruction and excretion: intrahepatic cholestasis, example hepatitis and drugs. Second one is extrahepatic obstruction, example gallstones, tumors and biliary atresia, and some genetic defects, example Dubin-Johnson syndrome.
Moving on to the next slide, here are some of the common diseases of conjugated hyperbilirubinemia. First up is hepatocellular causes, which causes liver cell damage. These impairs with liver's ability to excrete conjugated bilirubin in the bile. First is viral hepatitis and alcoholic hepatitis. Second is genetic disorders. There are two main genetic disorders of conjugated hyperbilirubinemia. First is Dubin-Johnson syndrome. It is because of defective bilirubin transport. Both the genetic disorders of conjugated hyperbilirubinemia are caused by autosomal recessive trait. Dubin-Johnson syndrome is an autosomal recessive trait which leads to defective excretion of conjugated bilirubin. So conjugated bilirubin is increased in blood, therefore there is defect in transport of conjugated bilirubin in diet. The bilirubin gets deposited in the liver and the liver appears black. This condition is referred to as black liver jaundice. Another genetic disorder is rotator syndrome. which is also an autosomal recessive condition. In this condition, bile excretion is defective, but there is no staining in the liver. And there are neonatal causes also. Some clinical features of conjugated hyperbilirubinemia. First up is jaundice. In jaundice, there is yellowing of skin, sclera, and mucous membrane. Here up we can see neonatal case of jaundice where the child is seen having pale sclera. And next up is dark colored urine due to insoluble water conjugated bilirubin being excreted in urine. There is dark color of urine, and it can be considered as a very early sign of conjugated hyperbilirubinemia. Next up is pale or clay colored stools. This is because of lack of bile pigments in stool. This is seen in obstructive or severe hepatocellular diseases. Fatigue and malaise is common with underlying liver diseases. Examples are hepatitis and cirrhosis. Next is abdominal pain. Abdominal pain, this is particularly in obstructive cases. Example, gallstones and pancreatic cancer.
Now moving forward, we have some diagnostic tests and their findings. Total bilirubins is now increased, direct bilirubins get increased, ALT, AST may increase, ALP, GGP is also high, urine bilirubin is present, stool color may be pale or clay colored. So, last but not the least, conjugated hyperbilirubinemia is not only a disease but a clinical sign of underlying liver or biliary disorders. So, early identification and treatment of cause of disease is very crucial to prevent any other further complications. Thank you.
One photograph was given for the child. The predominant jaundice is basically unconjugated type of hyperbilirubinemia, not conjugated. Okay, so you should not have shown that picture. Second, the classification point, what she had told, one point is definitely hepatic jaundice, that is more common. But the second point must come as obstructive jaundice. There is no mention of the common causes of jaundice. Instead, you have shown the Dubin-Johnson syndrome, Rotor syndrome, which are very, very rare. You may find 1 or 2 cases in your lifetime. So, commonly conjugated hyperbilirubinemia is most commonly seen for the hepatic type of jaundice. It's a hepatocellular jaundice. And second one is obstructive jaundice, and mostly you will get it due to gallbladder stone or maybe an obstruction to the biliary tract, usually carcinoma of the head of the pancreas or anything.
Intrahepatic obstruction. Causes for conjugated hyperbilirubinemia. Go back. And listen, the sensor is here, not there. Okay, so you point here. Now, hepatitis and drugs. What drugs? History of what will lead to conclude that he or she might have intrahepatic cholestasis. Anyone from the crowd? Anti-malarial drug. History of malaria treatment. Correct? Now suppose there is a gallstone. What are the different ways to get rid of gallstones or obstruction, intrahepatic or extrahepatic? Is there any way you can get rid of intrahepatic obstruction? What is the treatment?
So,
what is the procedure you perform to remove the intrahepatic cholestasis?
So we will inject drugs from outside.
Intrahepatic obstruction. How do you remove? Now you say genetic defect, Dubin-Johnson and Rotor, but you did not mention what is the defect. Correct? So when you say for this topic, you should have started from this slide. Bilirubin formation is not asked here. Unconjugated and conjugated differentiation is not asked here. It's a very small topic, conjugated hyperbilirubinemia. So what are different causes for conjugated hyperbilirubinemia? Extrahepatic and genetic disorder. Intrahepatic, extrahepatic, genetic disorder, that's all. You start, this should have been your second slide.
Sir, actually our topic were conjugated hyperbilirubinemia. So the conjugated word has to be like,
We know that. We are learned council, don't worry about it.
so we thought of so.
It is a seminar topic, so short topic has been given. It's not a class. You are delivering seminar. Seminar is given not to layman, to a learned council. You can start from the conjugated bilirubin. Okay. Oh. Anyway, presentation was good.
Thank you.
Good morning, everyone. So today our topic is blood pH regulation. Blood pH regulation, generally we known as the acid-base balance, and its normal range is 7.35 to 7.45. And the most important thing, it maintains the homeostasis in our body. Now we will see why blood pH matters. At first, we will see at the enzyme function. Optimal pH is essential for enzyme activity, driving metabolic reactions throughout the body. Now, the cellular integrity, extreme pH values can damage the cell structures. And at last, we will see the organ system. Proper pH ensures the efficient functioning of all organ systems from cardiovascular to neurological. Now, we will understand the pH, regulation of the pH.
Understanding pH, acids, bases, and normal blood range. What is a pH? pH is a measure of the hydrogen ion concentration in a body, which indicates acidity or alkalinity. If there is an increase in the pH, then there is alkalinity. If there is a decrease in the pH, then there is acidity. In a human body, there is an effective and tightly controlled pH range, which is from 7.35 to 7.45 in the arterial blood, which is vital for cellular survival and metabolic efficiency. Now, what if there is any deviation in this range, which can cause serious conditions like acidosis or alkalosis, which can be life-threatening if left untreated. In extreme cases, when the blood pH rises above 7.8 or falls below 6.8, life becomes unsustainable. So what does our body do against this to maintain the pH levels? Our body uses buffer systems.
See, we can't understand what you are speaking. We hardly you are audible. And what is written, that also we cannot read. And that is not written for you read. It is written to be read by us. Fine. And about pH we don't know. About normal pH also we know. Topic is pH regulation. Go to that slide, please.
Sir, there are what the body uses are what the body.
Be louder.
So, if there is a pH change in a body, what does our body do to maintain that pH levels? Our body uses buffer systems, respiratory regulation and renal regulations. And if you look deeper into the buffer systems, it is the first line of defense by our body. It is an immediate chemical neutralization, although it is temporary. And if we look deeper into the buffer systems, it can be of three types. First being the bicarbonate buffer system, which is in the extracellular fluid, which breaks down strong acids and bases into weaker forms into maintaining this delicate pH balance in the body. Second being the phosphate buffer system, which acts on the intracellular fluid and renal tubules, regulating pH within cells and in urine. The third one being the protein buffer system in the erythrocytes. The protein hemoglobin in the red blood cells can bind or release hydrogen ions, making it an effective buffer due to their amino acid components. Buffer systems act as the first line of defense, providing immediate yet temporary resistance to pH changes.
হচ্ছে না
উল্টো করে ধরে দিচ্ছে বাবা মেশিনটা। ও
আচ্ছা
আবার পিছনে যাচ্ছে।
okay. So let's talk about the respiratory regulation. There is a 3 line of defense. The first one is the let's talk about the respiratory system regulation.
এই মাইকটা এখানে নিয়ে আমরা কথা বল, যেভাবে কিশোর কুমার গান গায়।
Okay, sir. So it's time for the respiratory regulation. There is a 3 line of defense present here. First of all, the protein buffer system, phosphate buffer, or the bicarbonate buffer, the hemoglobin buffer present. And this is the second line of defense. This is more potent than the first one, but less potent than the renal regulation. So the respiratory system plays an important role in regulating the blood pH by controlling the elimination of the carbon dioxide by the 2 processes called hyperventilation and hypoventilation. And when the pH drops, that means that when the hydrogen concentration in the blood increases, then the chemoreceptors, that means the aortic bodies and carotid bodies that are present in the arch of aorta and the carotid artery respectively, and stimulate an increase in the breathing rate and depth, that hyperventilation, and expel more CO2, thus reducing the carbonic acid and the blood and raising the pH. That means the chemoreceptors detect the change in pH and also the fall in pH, and by the process of hyperventilation they excrete more amount of CO2, and thus the pH raises in the blood, because the carbonic acid concentration will also decrease in the blood. And reversibly, if the blood pH rises and becomes the alkaline, the breathing slows down, there is the hyperventilation and retains CO2, and this is exactly opposite to the first process. So
now moving on to the renal regulation, the kidneys long-term pH management. Excretion of H plus ions. The kidneys excrete excess H plus ions into the urine, directly removing acid from the body. Second, reabsorption of bicarbonate. They reabsorb bicarbonate ions from the renal tubules back into the blood, maintaining this crucial buffer. Third, the production of new bicarbonate. In response to acidosis, the kidneys can generate new bicarbonate ions, a powerful mechanism of long-term pH correction. The kidneys provide the most powerful, albeit slower, mechanism for maintaining acid-base balance, crucial for chronic conditions.
The normal value of the pH is 7.35 to 7.45, but there are various clinical conditions where the pH level may decrease or increase in the blood. When the pH level decreases in the blood, it is called the acidosis, and when the increase is called alkalosis. It is divided into 2 subclasses in each, that is the respiratory acidosis. In the acidosis part, there is a 2 subclass, respiratory acidosis and metabolic acidosis. In the alkalosis, there is 2 part also, and respiratory alkalosis and respiratory acidosis. Okay, so in the acidosis, the pH falls 7.35 as I said before, and the respiratory acidosis, it is caused by the impaired of CO2 removal, and it happens when the hypoventilation, or in the case of lung disorders, when the proper ventilation is absent in that case. And in the metabolic acidosis, due to the excess acid production and the bicarbonate loss, diabetic ketoacidosis and the kidney failure.
Now we will see the alkalosis part. The alkalosis mainly happen because the blood pH rises above 7.45, and there are 2 parts: the respiratory alkalosis caused by the excessive CO2 removal, and the metabolic alkalosis due to the excessive bicarbonate retention or acid loss. And here is an overview of this topic. There is buffer system, respiratory system, and renal system.
আরে একটাও লেখেনি, একটাও পড়েনি, এখান থেকে দেখে পড়ছে, কিন্তু এটা লাভ কি? ওইটা দেখে পড়তে হতো, ওরা টাইম চলে গেলে হতো, আমার মনে নিতাম। তো বলতো কিভাবে করে? What is the kidney regulation method? না দেখে বল।
The kidneys regulate the
শোনো, উইদাউট প্রিপারেশন আসবে না সেমিনার দিতে। রিডিং পড়া কাজ হয় না। This is not at all a presentation. Nothing. Others will say, this is not the way you prepare presentation. This is the worst possible way to present. Extreme. Best and worst. This is the worst. Okay? And this is the worst possible way to present on the dais. Completely reading thoroughly from top to bottom. Nothing doing. Not good.
so Mr. Balam, it's a question.
সবাইকে প্রিপেয়ার করে আসতে হবে, এটা কারোর একার নয়।